Our last but not least presenter for this morning is Dr. George Nassan. We're so excited to have you here this morning. Dr. Nassan is Associate Professor of Neurology at Mount Sinai, where he serves as Medical Director and Co-Chief of Behavioral Neurology and Neuropsychiatry, Co-Medical Director of the Barbara and Maurice Dean Center for Wellness and Cognitive Health, and Vice Chair of Ambulatory Operations and Quality in the Department of Neurology. Clinically, Dr. Nassan focuses on dementia care, including management of hallucinations and delusions, and on providing supportive and palliative care for patients living with dementia. He completed medical school at the American University of Beirut, neurology residency at Case Western Reserve, and a fellowship at UCSF, where he later became Director of Clinical Services for the Memory and Aging Center. He holds a master's degree in healthcare delivery leadership from Mount Sinai. Dr. Nassan is board certified in neurology and UCNS certified in behavioral neurology and neuropsychiatry, and brings both clinical expertise and leadership in dementia care to his work. Thank you so much for joining us for your talk this morning.
Thank you. Really appreciate it. I appreciate the introduction also. So we're going to talk today about the dementias that aren't Alzheimer's disease that could afflict our older population. I have nothing to disclose. And hopefully by the end of the session, everybody will be able to identify the various clinical presentations of degenerative diseases, including dementia with Lewy body disease, frontotemporal dementia, and primary progressive aphasia. These will be the focus of the talk today. And understand the anatomical and pathological substrates underlying these conditions, as well as recognizing how treatment care plans can be designed and individualized, for these different presentations. So we will start by just introducing degenerative diseases in general, and then dive into dementia with Lewy body, then frontotemporal syndromes, including the behavioral variant, primary progressive aphasia, and then conclude at the end. So neurodegenerative diseases are a group of conditions that result in progressive loss of brain cells, which is neurodegeneration, and therefore brain function. They are usually associated with some sort of a protein accumulation, but there's unclear yet causality of these protein accumulation. For example, in Alzheimer's disease, it's pretty well known that amyloid plaques and tau tangles, are present on the brains of people with these conditions at autopsy. There are other conditions related to protein tau without amyloid. Various tauopathies exist, such as corticobasal degeneration, Pick's disease, PSP. Another protein that could accumulate is alpha-synuclein, and it can clump into what we call Lewy bodies, therefore giving us Lewy body disease and Parkinson's disease. And then TAR DNA binding protein, or TDP43, is also another protein that could accumulate and cause frontotemporal lobar degeneration. There are other examples of these, such as genetic prion disease, fusion sarcoma, so on and so forth. It's important to understand that different dementia syndromes present according to which anatomy they are causing, and not always necessarily what the pathology is. So for example, the most common probably of dementias is the amnestic presentation of Alzheimer's disease, usually localizing to the brain where the hippocampus is and the parietal lobes. Posterior cortical atrophy is another potential manifestation of Alzheimer's disease, and the localization is different, and it affects the occipitoparietal region of the brain. And then so on and so forth. Logopenic variant is the left parietal. Dementia with Lewy body is a brainstem and limbic system disease. Richardson syndrome, which we say PSP, but really it's Richardson syndrome, is a cerebellar midbrain pathology. Corticobasal syndrome affects the paralimbic areas, and the frontotemporal dementia can have various different anatomies depending on what is causing it. All of this to illustrate that really the syndrome that we end up seeing, the phenotype, depends on the part of the brain, the anatomy that is affected by the disease. However, there are really a few pathologies that can cause the majority of these syndromes and present in different ways. So for example, if we take Alzheimer's disease alone, so amyloid deposition in the brain can manifest itself with the amnestic Alzheimer's disease, which we are all familiar with, but also with logopenic PPA. Some people present with features similar to dementia with Lewy body. Some people present with posterior cortical atrophy. Some people present with primary progressive aphasia, and so on and so forth. You can see how complicated the interaction between pathology and the phenotype, is. And therefore, it's really important as clinicians that we understand and diagnose specifically our patients with their particular syndrome and what we think the pathology is. And why? Why is it important? Why does this matter? Because we are entering an era where there are treatment differences. For example, we already have in the past few years new treatments for people with amyloid pathology in the form of infusion of monoclonal antibodies. Some medications can be contraindicated in some syndromes, like cholinesterase inhibitors should not be given to people with frontotemporal lobe degeneration. Also, some people, for example, people with Lewy body disease, are sensitive to medication, and we should avoid anticholinergic and other medication in these patients. But also, it carries a weight on how we counsel patients and their families about the prognosis, about the progression over time, about the potential of genetic involvement and repercussions on the rest of the family. Advanced care planning would differ, depending on the phenotype and the pathology. Also, we want to avoid unnecessary workup for things that we think we don't understand, but in reality, perhaps there is a way to clarify diagnosis. And we know from research, that was done to see whether if we confirmed the underlying biomarker of a condition such as Alzheimer's disease, does that change anything? And the results from the 2019 IDEA study was that there was a change to pharmacological, non-pharmacological, and counseling strategies if we utilize AD biomarkers for patients. And this is just for AD, let alone for other diseases. So for all of these reasons, it's important to recognize all of these different syndromes. So without further ado, let's start by talking about dementia with Lewy body disease. This is a common type of dementia. It's the second most common type of dementia following Alzheimer's disease in patients older than 65. And it is clinically defined as a progressive decline in cognitive function, usually accompanied by one of these four things: visual hallucinations, REM sleep behavior disorder, Parkinsonism, and cognitive fluctuations. The pathology of dementia with Lewy body disease really starts in the brainstem and moves up through the brainstem into the limbic structures, and then the last stage is really the cortex. So for a lot of the symptoms of Lewy body disease, they could be produced by just brainstem pathology, starting with the dorsal motor nucleus of the vagus nerve, which is in the medulla. And that's why a lot of people have constipation preceding Lewy body disease, because of the involvement of that nucleus. And then as it moves further into the pons, it starts causing things like REM sleep behavior disorder, potentially visual hallucination, because the pons has structures and connections with the occipital lobe and can lead to visual hallucination, as we know from stroke literature, people with strokes in the pons. And then as it moves up to the midbrain, it starts affecting motor because of the substantia nigra that's in the midbrain. So as you can see, almost all of the symptoms that define dementia with Lewy body disease can be contained in the brainstem. And for all we know, a lot of our patients that we are seeing have brainstem disease only. You may notice when you see such patients that their MRIs might come back normal because the cortex may not be affected, and therefore we do not see volume loss in the cortex, and their MRIs as read as normal or appropriate for age. In order to diagnose dementia with Lewy body, we still use currently the fourth consensus diagnostic criteria. Essential to this criteria is the presence of dementia. So there needs to be a progressive cognitive decline that is a sufficient magnitude to interfere with the normal social or occupational function or daily activities of the patient. And there has to be a prominent or persistent memory impairment, and deficits on test of attention, executive function, and visual spatial ability can also be prominent and occur early. There are four core clinical features, and we don't need all of them. We'll look at the criteria in a minute, but these are the four features. We kind of already brushed on them. So fluctuating cognition with pronounced variation in attention and alertness. This is an interesting and sort of sometimes difficult to recognize symptom, because it can look like somebody is unresponsive or having a seizure, and oftentimes it is misdiagnosed like a seizure. People go to the emergency room for it, and then in a few hours, everything's back to normal and nobody knows what happened. An evaluation with an EEG is unremarkable, but this is what fluctuation could look like. In addition to the fact that the symptoms of the disease could be worse on some days, but better on others. But the criteria of the fluctuation as part of the core clinical is the presence of these episodic sort of unresponsiveness or loss of interaction with the environment. Recurrent visual hallucination is another core criteria. The visual hallucination typically can be well-formed and detailed, but often can also be just hazy spots of shadows or lights that don't necessarily have like a formed figure. So they could take multiple forms. REM sleep behavior disorder is the inability to remain paralyzed during dream phase. We are all normally unable to move when we are dreaming, and this is orchestrated by our brainstem. In this disease, we lose that ability, and therefore, because dreams are very much lifelike, we start moving during them and we act out our dreams. And then finally, there could be one or more cardinal symptoms of Parkinsonism, including bradykinesia, slowness of movements, rest tremor, or rigidity. There are some supportive features that could occur, including being sensitive to antipsychotic agent, postural instability, repeated falls. Constipation is a big one and a very common one and can precede this. Orthostatic hypotension, feeling dizzy when we stand up, blood pressure dropping, urinary incontinence, hypersomnia could occur. Hyposmia or anosmia is also very common and can often precede these symptoms. Hallucinations and non-visual modalities such as auditory hallucination can occur. People can become apathetic, anxious, or depressed. And there are also some indicative biomarkers, which really the most commonly used one is doing a polysomnogram. So, a sleep study that confirms the presence of REM sleep without atonia. DAT scan is another type of nuclear study which can demonstrate whether the basal ganglia, the dopamine transporter is being uptaken in the basal ganglia. It has a 78% sensitivity, but a 90% specificity. So the being more specific means that the chances for false positive are lower, but it's not sensitive enough, meaning that there could be false negatives in 22% of cases. There are currently actually, and I didn't put that on my slide, but in the past year, there has been also development for new biomarkers for alpha-synuclein. There are two currently commercially available ones. One is a spinal tap, a CSF sort of study, that alpha-synuclein assay. It's similar to the RT-QuIC for CJD, but it looks at alpha-synuclein clumping. And it has a relatively good sensitivity and specificity in the high 80%. And then the other is a skin biopsy, which is done in three different locations, three different skin biopsies from the body, and detect alpha-synuclein, in the skin, and also has a pretty high, up to 90 sensitivity and specificity. So the diagnosis currently requires, for probable dementia with Lewy body, 2 core features or 1 core and 1 biomarker. So these are the current criteria. For possible dementia with Lewy body, you need only 1 core or 1 indicative biomarker from the ones that we just presented. And then usually, if the cognitive symptoms have preceded the motor symptoms by about a year, we call it dementia with Lewy body. And if the motor symptoms precede cognitive by about a year, then we call it Parkinson's disease. And for some people in the field, this is a little bit of an artificial dichotomy, because on autopsy, people with Parkinson's disease and people with dementia with the Lewy body are indistinguishable. That's the same pathology that we see in both brains, at least on autopsy. And then finally, it's important to recognize that there is such a thing as an MCI Lewy body, in the same way that there's an MCI, a pre-sort of dementia stage for Alzheimer's disease. And it could be indistinguishable from the MCI that we have in Alzheimer's disease. Sometimes the presence of loss of sense of smell, constipation, or REM sleep behavior disorder should increase our suspicion that this MCI might be leading to dementia with Lewy body with time. The cognitive pattern also can be more dysexecutive on your psychological testing, so more difficulty with executive functions. And then it's important to recognize this because the counseling, the diagnosis and the counseling and management could be different for people with MCI that we think is Lewy body versus MCI that we think is AD. That being said, and it seems like I'm contradicting everything I'm saying, but there's a lot of overlap between AD and Lewy body disease. And some believe that there could be on a spectrum of disorder, because studies have shown that about 66% of patients with clinical dementia with Lewy body have AD copathology at autopsy. So there's Lewy body pathology, but also AD copathology in 66% of cases. And then conversely, 60% of patients with Alzheimer's disease have Lewy body copathology at autopsy. There's a lot of interaction between these two pathologies with each other, and we still don't understand very well why or what mediates this, but there's definitely a lot of overlap between these two illnesses. And then biomarker positivity can also overlap, in patient before autopsy in patients, on whom we're doing this. And therefore, it's important to recognize that having a positive biomarker for Alzheimer's disease doesn't automatically rule out Lewy body and vice versa. So the clinical piece here is still important to be able to understand the phenotype. How do we treat dementia with Lewy body disease? Currently, there is no known cure or disease-modifying therapy. There are medications that we use to treat the motor symptoms of DLB, but these may worsen the neuropsychiatric ones, and then vice versa. Medication that we use to treat the cognitive neuropsychiatric manifestation of DLB can worsen motor symptoms. For the motor symptoms, we use levodopa carbidopa, similar to what we do in Parkinson's disease. It's advised to start at a very low dose. I often start with a half a tablet of Cinemat, once a day for a week, and then do increments of half a tablet every week in order to achieve, hopefully, improvement in motor symptoms, and watching closely for the worsening of visual hallucinations or cognitive symptoms. Visual hallucinations, if they are present, do not necessarily need to be treated if they are harmless. If they do need to be treated for whatever reason, they're causing, they're bringing harm or sort of safety issues, then cholinesterase inhibitors like donepezil are actually quite successful at treating the majority of these. And often these are patients in whom we push the dose of donepezil or rivastigmine or other medications above the regular dose. So for donepezil, I might go more than 10 milligram to 12.5 or 15. Rivastigmine, there is, you can go up to 12 milligram daily if it's by mouth, or 13.3 milligram for the patch, so on and so forth. Keep in mind that cholinesterase inhibitors may worsen motor symptoms. So you might start your patient on it. They come back and follow up. They said, oh, I feel better, cognitively is better, but I now have this tremor, which I didn't have before. And that's a very common scenario. And then we'll have to sort of see what is worth treating or what can we live with. It's really a negotiation of what are the symptoms with which we can live, or sort of like delay a little bit treating them, because each medication will have a side effect that bring on other parts of the disease. Olanzapine and risperidone has been found to be efficient also in treating visual hallucination when they are difficult to treat, but they have a lot of side effects associated with them. Quetiapine is safer, but it has not been as studied as olanzapine and risperidone. And then behavioral modification, such as it is very frequent that if you ask people where the visual hallucination occur, it's often a specific room in the house or a specific place or a specific corner or window. And often there is some sort of a reflective surface or a lot of complicated art or what have you, something that visually is challenging the brain. Removing these from the environment very frequently can decrease significantly the likelihood of the hallucination. So something to keep in mind and think about when you're seeing your patients. And then finally, depression and anxiety, which is common in dementia with Lewy body, can be treated with an SSRI. Citalopram and escitalopram are some of the least anticholinergic, and there are something that we avoid, like paroxetine, because it could be highly anticholinergic. These are some other medications to avoid in people with dementia with Lewy body, antihistamine being on the top of this, especially things like Benadryl, which can be very heavily anticholinergic. Alrighty, I will move now into discussing frontotemporal syndromes, and we're going to talk about the behavioral variant first and then primary progressive aphasia. So frontotemporal dementia was first described in 1892 by Pick. It is the second most common dementia in young individual, younger than 65, and the third most common in older adults after Alzheimer's disease and dementia with Lewy body. The age of onset can generally be younger, in 50s or 60s, but it can also occur later, in people in their 70s and 80s could have that. Especially some genetic forms can be associated with a later onset. The survival can be shorter for frontotemporal dementia, averaging 6 years in the literature. This is compared with an average of 11 years for patients with Alzheimer's disease. So FTD is really not one thing, but it's a group of syndromes, and what they all have in common is that they affect either the frontal or the temporal lobe or both, with a relative preservation of the posterior structures like the occipitoparietal lobes. The predominant symptom in FTD could be behavioral, in which case we call it behavioral variant FTD. It could be language, in which case we call it primary progressive aphasia, or it could be motor or executive function, in which case those two syndromes that are common are corticobasal syndrome and PSP, progressive supranuclear palsy, which we will not talk about in today's talk. And of note, just to understand sort of the definitions, when we say FTD, we are referring to the phenotype or the syndrome of frontotemporal dementia. When we say FTLD or frontotemporal lobe degeneration, we are referring to the actual pathology of frontal and or temporal atrophy. So let's start by talking about behavioral variant frontotemporal dementia. This is the most common subtype of FTD, and it often presents to psychiatrists or to psychologists in marital counseling sessions because it causes a lot of strain, especially between couples, and it is not immediately recognized as a neurologic disorder just because it affects personality and behavior, not necessarily motor or sensory or speech, things that we connect, more easily with the brain. There are 6 cardinal features which we're going to talk about in detail: disinhibition, apathy, loss of empathy, obsessive compulsive behavior, hyperorality, and executive dysfunction. We don't need to have all of them, but these are the 6 features that could occur in behavioral variant FTD. This inhibition is often the presenting symptom, and examples are people becoming overly friendly or approaching strangers, striking up conversations that could be too personal or explicit, and that there could be an excessive trust of stranger coupled with difficulty in making sound judgment, and that could make these patients vulnerable to exploitation, be it sexually or financial exploitation. They could be subject to online or telephone pranks, but please keep in mind that a lot of other people with Alzheimer's disease, Lewy body, can also be subject to that because of their dysexecutive difficulties. The anatomy of this inhibition primarily is the resultant of orbitofrontal cortex volume loss. This is the part of the brain that's right above our eyes, and in many ways it's kind of like the superego of the brain, you know, what kind of keeps our moral judgment and social decorum in check. Apathy is another feature. Apathy is defined as social withdrawal and decreased motivation. Examples include decreased interest in previous hobbies or an attitude of indifference to general things, losing one's job and not seeking to work again. And the anatomy primarily is in the right anterior cingulate gyrus. Loss of empathy is when people become more self-centered and lose the ability to understand other people's feelings. They may make rude remarks or gestures with disregards to other people, and being insensitive to someone's illness or injury. And that often is what the patients say in the office. Like, I was sick the other day and my spouse didn't care and wanted me to drive him, I don't know where. They can become emotionally distant and detached, and this creates a toxic dynamic for couples. The anatomy of this is primarily in the right anterior temporal lobe. Obsessive and compulsive behavior can also occur in behavioral variant FTD. People can become obsessed with specific thoughts and or display compulsory behavior, such as repetitively picking on things or chewing or lip smacking or pacing back and forth. They can have constant locking and unlocking of doors or windows. Hoarding behavior could be another example of that. People could become mentally more rigid, therefore less flexible to changes in plans or routines. Or they can eat specific types of food at specific times of day in a quite a rigid way. The anatomy of this is in the left lateral temporal lobe and the basal ganglia. Hyperorality is defined as inability to refrain from eating even after satiety is achieved. So people can eat as long as there's food in front of them, they can keep eating. In some more severe forms, the patients can also eat non-food items. And there's often a change in diet that's observed by the family, such as craving sweets or eating more junk food, and it can result in weight gain. Sometimes hyperorality manifests itself with excessively drinking alcohol or smoking or chewing. So especially if you had somebody who didn't drink alcohol during their lifetime or smoke and then suddenly picked that up, it is worth thinking about the possibility of a neurologic disorder underlying this sort of new habit in someone who is older in age. The anatomy of this denotes from the insula, but also the right orbitofrontal cortex. And last but not least, patients with behavioral variant frontotemporal dementia can have executive dysfunction as seen on their neuropsychological testing. Executive dysfunction are the function of our brain that involve things like making the right decision, planning, multitasking, organizing our environment, our thoughts, so on and so forth. So it's kind of like the CEO of the brain. And we can see a loss of these functions in people with behavioral variant frontotemporal. To diagnose BV-FTD, we need 3 out of the 6 criteria that we just talked about. This is per the 2011 International Consortium criteria, which we still follow to this day. For probable BV-FTD, you need to have possible, meaning 3 out of 6 criteria at least, and imaging results like an MRI showing frontal or anterior temporal volume loss, which sort of confirms the frontotemporal degeneration, in these patients. Of course, like every other dementia, some exclusion criteria includes that the deficits are not better accounted for by something else, inflammatory problems, psychiatric conditions, so on and so forth. FTD MND is worth talking about briefly because it's a common occurrence. So a lot of people can have an overlap between having a BV-FTD syndrome as well as motor neuron disease or ALS, Lou Gehrig's disease. BV-FTD can either precede or follow the typical features of ALS. And sometimes you can see this in people who have typical BV-FTD, but then they don't gain weight despite overeating, and that's because they are losing weight from the muscle atrophy that the ALS, could be causing them. In these patients, there's also the highest concomitant presence of psychotic features such as delusions and hallucinations. And a good number of these patients have an expansion in the C9orf72 gene. We're going to talk about this in a little while. But familial FTD-MND is a common occurrence and one of the most common sort of familial manifestation of frontotemporal dementia. The pathology of FTD can be grouped either under tauopathies or TDP-43-opathies. For tauopathies, we have Pick's disease, CBD, and PSP. All three can cause FTD. And by that, I mean that PSP pathology causes FTD syndrome, not PSP syndrome, meaning the patients don't have to have frequent fall or whatever we associate with PSP as a syndrome, but they have a typical behavioral variant frontotemporal dementia, and at autopsy, the underlying pathology can be PSP. TDP-43 tauopathies come in a few flavors. The most common ones are A, B, and C. A being associated with the progranulin gene, which also we're going to talk about. B being associated with the C9 gene, and C is almost always the somatic variant of primary progressive aphasia. So just a few minutes on genetics. 40% of people with FTD have a family history, so this is pretty high. This compares with, it's about 25% of people with Alzheimer's disease have a family history of dementia. And 10% of people with FTD have a genetic cause, meaning an autosomal dominant genetic heritability, compare with less than 1% of people with Alzheimer's disease. So BV-FTD is really the largest proportion, contains the largest proportion of familial cases. There are three genes that are the main ones. There are a lot of other genes that cause FTD, but I'm going to talk about the three main ones and in the orders in which they were discovered. So MAPT is the microtubule-associated protein tau gene. It's on chromosome 17, and it's mutated in about 3 to 14% of people with clinical FTD, and more in about 30 to 40% of those that have a family history of FTD. The typical age of onset for that gene is 50. The progranulin gene, which was discovered not that long ago in 2011, is also on chromosome 17. It is seen in 1 to 16% of FTD cases and 8% of familial forms. The age of onset can be 62 on average, but also can be later in the 70s, 75, late 70s. And in these patients, there's often an asymmetric degeneration, like one hemisphere degenerates more than the other, causing either a prime progressive aphasia if it's the left or a BV-FTD if it's the right. And also these patients can have some Parkinsonian features on their examination. And then last but not least, the C9orf72 gene discovered in 2012. This is not a mutation, but an expansion in the non-coding GGG-GCC hexanucleotide of the gene called C9orf72, which is really its location. It's on chromosome 9, open reading frame 72. It's the most common genetic mutation in familial FTD and in familial ALS. So that gene can cause both FTD and ALS. The age of onset is 60, and there's a lot of delusions and psychotic features in people with this gene expansion. And on MRI, we could see cerebellar involvement or thalamus involvement, and that also can manifest itself with specific phenotypes. For the management of BV-FTD, there is also no disease-modifying treatment. There are some clinical trials that are happening for specific gene mutation, like the progranulin mutation. Educating the patient and the family about this is really important, as well as if there is suspicion for a gene mutation, to counsel them appropriately about it, because it can have repercussions, on the rest of the family. Referral to social worker, as well as support groups, maybe home health aid, daycare center, could be important. Identifying any accompanying syndromes like Parkinsonism or ALS is also important because it has relevance on their prognosis, but also their quality of life and how to treat it. If ALS is of suspicion, refer to a neurologist and neuromuscular specialist that could do an EMG for confirmation. As we said, genetic counseling and testing might be important. Some of the aberrant behavior can be treated with an SSRI. Paroxetine is the most studied, but as we know in this group, it is not really advised, in people of that age group, and it can have a lot of anticholinergic side effects. So instead, We can use citalopram or escitalopram. Trazodone has also been studied with some good success in sort of helping with agitation as well as hypereating syndromes. Antipsychotics for agitation and disinhibition can also be tried. Olanzapine and risperidone, again, are the ones studied that more. But there's in general little evidence, for all of these things. And avoid cholinesterase inhibitors in these patients. They can make symptoms worse. So donepezil, galantamine, rivastigmine should not be given to somebody with FTD. And then for the last part of the stock, the primary progressive aphasia, which is also under the umbrella of FTD. This is a syndrome in which there is progressive decline in language. Usually the first 2 years, the prominent symptom should be language in order for us to call it PPA. And there are 3 primary subtypes, which we're going to talk about in detail, affecting the frontal part of the brain, the anterior temporal lobe, or the posterior part of the brain. So the non-fluent variant of PPA results in difficulty in speech production, often presenting as either agrammatism or apraxia of speech or both. Agrammatism is difficult together understanding the grammar of it. So it's both producing grammar, but also at times understanding grammar. So patients might start having complications understanding sentences that contain things like adverbs or things that change the structure, like I went home before I did X, Y, and Z, and the before, they have a hard time figuring out what that means. Apraxia of speech is difficulty in producing the motor choreography of how we move the muscles of our mouth and tongue and throat in order to produce sounds. So the sounds may come up distorted or with substitution of syllables or extra syllables or deleting of syllables, so on and so forth. Usually people are aware of this because they speak and then it comes out not like they heard it in their head, and they become really frustrated because of that. The non-fluent variant can also present with motor findings, especially in the right arm, because it affects the left hemisphere in most people. So they can have rigidity, slowing, reduced dexterity. The anatomy is in the left perisylvian region, or what we call the opercular region, and the pathology can be PSP, CBD, or TDP type A. This is what the MRI could look like. You can see the inferior frontal lobe here almost disappearing within 4 years. The semantic variant of primary progressive aphasia is one in which there's progressive loss of semantics. That's knowledge, vocabulary of words, but also object knowledge. People remain fluent in their speech because they simply stop using the words that they lose, in the same way that we don't use words that we don't know that are in the dictionary. They may have surface dyslexia, which means to read things phonetically as opposed to how they're supposed to be. Especially in the English language, there's a lot of irregular words, written a certain way but pronounced a different way, and that's just knowledge. And because we are losing that, people start reading everything phonetically. Speech may contain a lot of non-specific words like thingy, animal, stuff, and they may ask about specific meaning of words, in conversation. These patients usually have TDP-43 type C. The disease can spread from one hemisphere to the other hemisphere within 3 years, and then to the frontal lobe within 5 years, causing a BV-FTD syndrome. So many people with this disorder start by being called PPA because of the language problem, and then a few years later are called BV-FTD because of the disinhibition and behavioral problems. This is what you can see on the MRI. And finally, the logopenic variant, just for completion, but this is not an FTD. The logopenic variant is a manifestation of Alzheimer's disease, and it affects the posterior parts of the brain, specifically in the temporoparietal junction. People present with problems in phonologic processing of language, meaning the sounds of language. And if spoken to long sentences or long paragraphs, they may not get all of it, but also when they are speaking, they have a lot of word finding difficulties, and they pause a lot in their speech because they cannot hear the word. They blank on the word. They can't hear what it sounds like. And this can be really frustrating and cause a lot of anxiety. They can also have difficulty with calculation just because that part of the brain is very close to the temporoparietal junction and can be affected in the disease. So the anatomy is the angular gyrus, or what we call as the temporoparietal junction. And often, more than 90% of the cases, the pathology is Alzheimer's disease. So the management of PPA is similar to that of FTD, disease-modifying treatments, so on and so forth. Speech therapy is really important, and starting it early can help sort of maintain communication for as long as possible. And there are different strategies for different variants. So script training could be a strategy for people with non-fluent variant, but word retrieval or semantic relearning can be a strategy with semantic variant, so on and so forth. A swallowing evaluation might be important, especially in people with non-fluent variant, because they can have motor problems affecting their swallowing as well. And then treating any associated motor or movement symptom with a trial of levodopa carbidopa can be helpful. So this is the end of the talk. I will quickly just summarize what we just discussed. Neurodegenerative conditions present with various clinical syndromes, usually dictated by the underlying brain anatomy of the disease. Dementia with Lewy body can mimic Alzheimer's disease, but has specific features that we should understand and try to elicit, such as REM sleep behavior disorder, visual hallucinations, and fluctuation in sensorium. When the frontal lobe is involved, patients can present with behavior, language, or motor executive syndromes. And clinical syndromes in general may result from different underlying specific pathologies, and one pathology can present itself with various different clinical syndromes. It's important to understand all of these things because treatment could be different, and it remained currently centered around symptomatic relief wherever possible, support, anticipatory guidance, and education. Predicting the underlying pathology help us inform how we guide patients, but also it might be important in this era where disease-modifying therapies are emerging. I hope we achieve the objectives, and any questions I'm happy to take.
Thank you so much for this fantastic talk. We have a couple of questions in the chat for you.
Great.
Someone is asking, what do you find the most difficult symptom to manage in frontotemporal dementia?
That's a very good question. I would say apathy is probably the most difficult, and it's the one that gives families the most distress. Believe it or not, it's not disinhibition. Most of the time, people are very easily taken out or reoriented because they're apathetic, so that they don't care enough to fight with you over what should happen or not happen. And the apathy becomes more problematic, where they're sitting home most of the time doing nothing. It can be quite distressing to the family, especially for the young onset, like people in their 50s who might have kids that are of age of, I don't know, requiring love and care from the parent and involvement in their life. I mean, these things can be very distressful. I think apathy is probably the most difficult one.
And I know you touched on it a bit in your talk, but I wonder if you could expand on how you manage apathy for those patients, or what you try.
I know it's really hard. I think SSRIs can be really helpful. I often start by putting them on, a 10 milligram of Lexapro, which can be up titrated, if needed, and see if that helps. Some studies, although I don't know, I have to sort of look more into these, have tried to look into using psychostimulants like methylphenidate for apathy. These come with a price to pay because there are psychostimulants, and so other things that are undesired could be stimulated. Especially, for example, if people could be prone for things like delusion or obsessive compulsive behavior, and these could then occur more frequently in these patients. So that's really difficult and problematic. And I wonder, we are in an era where people are testing a few different things, transmagnetic sort of cranial stimulation. People are trying to see whether deep brain stimulation for things other than movement could, help. I think all of these are still in experimental stages. So for now, we have the medications that we have, like the SSRIs, to try.
Thank you for that. Speaking of experimental treatments, someone is asking, what do you see in the next 10 to 15 years in terms of treatment advances for these diseases? What are you hoping for?
I bet that we're going to see something similar to what we saw in Alzheimer's disease, meaning first, some sort of progressive scientific development in finding biomarkers for the specific underlying pathologies. And once we're able to specifically say this person has TDPA, or this person has Pick's disease, or this person has CBD, then we're going to see an emergence of disease-modifying treatment that target that particular pathology. We are already seeing this in the genetic forms. That's why the majority of the current clinical trials are in genetic forms, because they know that all of the people with that gene are going to have the same underlying pathological substrate, and therefore designing a treatment for this and testing it, makes it more viable than saying, well, we have no idea, all of these people fall under BVFTD, but they could have different pathologies, and how do we develop treatment for them? So I think we're going to see a development similar to what happened to Alzheimer's disease in the past 10 to 12 years, where first the biomarkers came, and we were able to identify with a level of specificity, who has Alzheimer's disease while still alive and not waiting for autopsy. And following that, disease-modifying treatment occurred. So I think this is probably what will happen in the next, hopefully, 5 to 10 years.
Very exciting. And sort of related to that, someone is asking, a bit outside the scope of your talk, but if you could speak to the utility of the new monoclonal antibodies for Alzheimer's disease.
Yeah, absolutely. So these are the first disease-modifying, treatments that are available for Alzheimer's disease. They're not perfect. They're not the best thing that we have, but it's kind of the same thing like when we first had the first sort of multiple sclerosis disease-modifying medication. They were not great, but they were something to start with. When we first had the AZT for, HIV, they were not perfect. They were not great, but they were something. And I think this is where we are in Alzheimer's disease. So hopefully some future medication will be even better. But the current ones that are available, there is some good evidence that some people do respond well to them. So far, the benefit has been shown primarily in people with mild cognitive impairment and early Alzheimer's disease, where the symptoms are still relatively more or less not affecting day-to-day function. And while there's great evidence that the medication are good at removing the plaque, so most people, when on a repeat amyloid PET scan or CSF testing or whatever, there's no more, biomarkers, which is great. They were not able to demonstrate that that stops the disease or cures it, and the disease has continued to progress, but at a slower rate than people who were receiving placebo. So there's some benefit. The big caveat with these medication is the risk profile. The side effects could be quite detrimental, including bleeding and swelling in the brain, which can occur 20 to 32% of patients, depending with which medication you use. Some of the medication have less risk than others, but also that risk is mediated by genetic factors. So the presence of ApoE4 can increase the risk of bleeding and swelling, which is a difficult one because most people with Alzheimer's disease will have an ApoE4 because that's also a risk factor for Alzheimer's disease. So far, I think practically the way that it's coming down to in the office is it's coming down to people's personality more so than the science, in the sense that we find somebody who's eligible, we counsel them about it. Most people are making decisions based on their own sort of risk-taking behavior or not, how safe they want to be, how risky they want to do this. But I think it's really promising, and it's great that we do live in an era where these options exist and we can offer them and we can learn from them and hopefully have better, more refined treatments down the road.
Thank you so much for that answer and for your really wonderful talk. We appreciate you joining us today.
My pleasure. Thank you for inviting me. I appreciate it. Thanks so much.